and welcome to the Multidimensional Family Therapy webinar, Part 1. I'm Cynthia Rowe at the University of Miami, and I'm happy to spend the next 3 weeks doing this webinar and talking about multidimensional family therapy. And I was asked to go through just some housekeeping details that I think you'll see on your screen there. You can use your computer speakers or a headset for the audio. If you need technical assistance, they've asked you to dial 1-800-504-5379. And during the webinar, you can click on the Q&A tab below to type your questions or comments. And please feel free to write questions, and I'll take a few breaks here and there to take time for questions. And this will be a 3-part course. We'll be talking today from 2 to 4, and then next Wednesday, November 3rd, and the following Wednesday, November 10th. All 3 sessions are from 2 to 4 Eastern Time. They have specified you must attend all 3 sessions to earn CEUs. And after the 3rd webinar, you will receive an email with the PowerPoints, a webinar evaluation, and requested CEU certificate, and a link to the recorded session. So I believe that is all the housekeeping that I needed to go through with you. But the one I would stress the most is please ask questions so I can address your specific interests and concerns. So I'm ready to start. The next slide, the overview of multidimensional family therapy, which is a best practice model for adolescent drug abuse and delinquency. And this is an approach that's developed over 25 years now with a team. We're based now in Miami, but we've been in different parts of the country, and we've worked with many, many great people around the country and more recently around the world to develop the model and to implement it and to study it so that we know that we're doing the absolute best we can to get the best outcomes for kids and their families. So next slide, please. We will just talk a minute about treatment outcomes. We've got, as I said, over 25 years of research, so it takes we can do a whole webinar just on the research on MDFT, but we won't do that. We're going to just talk a little bit about the summary of treatment outcomes that we've found. And our research has shown we have 10 clinical trials that we've completed, and we've shown in these different studies we've got good evidence of reductions in substance use. So if you look at all these studies together, there are substance use reductions up to 12 months, and in our more recent studies, longer-term follow-ups have shown the maintenance of those reductions. So in our research, we also show that individual functioning of the teenager, not just the conduct problems and delinquency and that, but also internalizing symptoms, so depression and anxiety also reduce over time. And we have a couple studies showing depression and anxiety symptoms reduce up to 12 months and even longer in some recent studies. MDFT also affects the adolescent school and functioning in job and vocational functioning. And in one of our early studies, we actually showed kids were in MDFT able to move from failing grades on average into the C range, which was passing, which was quite an important outcome, of course, because school is so critical for teenagers to launch well into adulthood. And we also show in our studies effects on parenting practices. And so, as you probably can guess, we do a lot of work with parents and families, so our research does reflect that we're able to show parenting practices improve, that parents become more effective in their discipline, in their follow-through, monitoring, and also the family environment becomes less conflicted, and it becomes a more cohesive environment for the teenager and for parents, which is good. Teenagers show fewer arrests over time, and actually, interestingly, in comparison to treatments that are peer-based, MDFT actually has greater effect on reducing the affiliation with delinquent peers and drug-abusing peers. So that's a very brief overview of the research. And if you are interested in finding out more, we've got plenty of interesting research reviews and things that we can send to you. So please let us know if you're interested in more details about that. Next slide, please. We'll be talking a little bit about theoretical and clinical roots of MDFT, and the model has been based on different roots, and also in research. So the model itself is very much based on research on adolescent development. So the last, say, 20 years, there's been really fabulous research on exactly what happens during adolescent development, and recently even brain development. So we've used a lot of these research findings to make the clinical model appropriate for adolescents and to address adolescent development and parenting, actually. So the research that shows adolescents are in a state of transition, parents are in a state of transition as well. So the model itself is actually designed around these research findings. The third root of MDFT is in the research that identifies risk and protective factors for adolescent problems. And there are a host of risk and protective factors for adolescent drug abuse and delinquency. Many have been identified in research studies and have shown to be pretty consistent. So at this point, we know pretty much what they are. They are in the adolescent domain, things like resiliency, things like a lower IQ would be a risk factor. In the family, we know many of the risk factors, such as family conflict and parental drug abuse, parental psychopathology. Risk factors in the environment, a school that isn't very well structured, or a school that's got lots of gang activity and not great resources. So we know the risk factors. Peers, of course, can be a protective factor or a risk factor. So the model is really designed to address to promote the protective factors against adolescent drug abuse and delinquency, and as well to reduce the risk factors. So you'll see as we continue the way that the model is designed around how to bolster protective factors and reduce the risk. The fourth root is really comes from Uwe Bronfenbrenner's theory of or ecological perspective, and his some of you probably know very well the circles that are sort of overlapping in the world of the adolescent or of any person. So these circles of influence go increasingly broader in someone's life, and we attend to the multiple ecologies of an adolescent's life, and that starts with a little circle of the adolescent and gets larger, so the family, the peer group, the school, and other systems. So our system's very multi-systemic, and so we don't just address the adolescent, of course. We're addressing each system of influence, and so we go so far as to address the multiple systems, the court, the school, the health systems that may be impacting the family as well. And, of course, the model has been heavily influenced by family therapy theory and family therapy traditions, such as structural family therapy, Sal Minuchin, and also problem-solving therapies, Jay Haley. So the developer of this model, Howard Little, who is professor at University of Miami, his mentors were Drs. Minuchin and Haley and others, and so his roots are very much in family therapy, and the model developed from there. So I think we'll go on to the next slide. Those are the roots. And so if we sort of sum up our theory of adolescent problem behavior, the way that we think about what we have to have a theory of what's gone wrong before we're going to have a theory of how to change it. And so the MDFT theory of adolescent problems are, of course, that we know adolescent substance abuse is multifaceted, that a lot goes wrong with teenagers that are into drugs. They don't end up getting into trouble with drugs and delinquency by accident. So this is something we would tell families as part of our first session, that adolescent substance abuse is a problem that has many determinants, many factors that go into it. So risk factors mutually influence themselves, and we know that protective factors can buffer against deviance. And so that even in the worst case scenario, if a teenager may have many risk factors, but even a strong parental system or a good network of friends can really buffer from those risk factors. We know that adolescent problems happen and are defined in context. So adolescents don't get into trouble just for no reason, and just because they're bad, or those kinds of attitudes that are kind of easy to get caught up in. But we know adolescent problems have meaning and context to them. We know adolescent substance abuse and the problems that go along with it are systemic problems. So, of course, that leads to a systemic way of thinking about the solution. So our research shows, and we know from just our own experience, the family is the primary context of healthy development. So everything happens in the family, even kids that are in and out of the home and many placements over childhood and adolescence. Their family is still the critical socializer, and in good and maybe negative ways. So this has to be a primary context of intervention. And even though peers are very influential and increasingly influential in adolescence, the influence of peers always operates in the relationship with family members. So, and again, we go back to the adolescent development research that peers become important, but families have kind of an overriding influence in terms of values and relationships and influence. So, let's move to the next slide. That given all of this, our theory of how things go wrong or how kids get into problems, we'll talk in the next slide about MDFT's theory of change. So if we put all that together with our theory of the problem behaviors, our theory of change is that adolescents need to develop positive, strong, supportive relationships with parents, that this is one of the essential ingredients in kids doing better, and the symptom reduction and enhancement of prosocial development occurs not just by targeting the family by itself, but also facilitating processes across life domains. So we don't actually believe that changing the family is enough, or just working with parents. So we don't have a model that just does parent management or parent practices. We work in all these different domains. We're really trying to harness every possible way to help kids change, and so hence our multidimensional model. And we'll move to the next slide, just a continuation of our theory of change. So problem behavior can desist, it can be reduced when there are meaningful, concrete alternatives to the current behavior. So as everyone knows, if you just tell someone not to do something, that's not enough, and it's certainly not enough for our kids. So what we do in our therapy and what our theory of change tells us is that we have to help kids and families together to create new alternatives, new ways of being together. so that they can really practice, accept, adopt just a whole new way of life. And that's really how we think about our treatment, is really we're trying to help kids really get a whole new life and change in all the positive ways they possibly can, and to let go of the negative identity, the negative influences. So the next little bullet there says that this is kind of our bottom line, that if it has been multiple risk factors and a network of influences that create and maintain adolescent problems, then those same complex of interrelated influences must be systematically targeted for change. So that's a kind of wordy way of saying that if we know, which we do from lots of research and lots of clinical experience, if we know that there are many, many factors involved in teenage drug abuse and delinquency, we know what they are. We know, as we've talked about, the risk and protective factors. So if we know it's these set of influences that determine adolescent problems, then it's these same things that have to be changed to change an adolescent's life, to completely take their trajectory from the way it's going, which is usually not going so well, into a whole new trajectory, into a whole new way of kind of being, and a whole new way of an adolescent thinking about themselves and being in the family, being at school, being in the world. So that's a very short way of explaining our theory of change. And I thought I might actually take questions here if anyone would like to type in some questions, and anything on just the background, the research, the roots, the theory of problem behavior, or the theory of change. And I'll take a minute here so you can type in questions if you have any. I can read your questions. So, and again, that's in the Q&A. If you go to that little tab. Okay. So I don't see any questions this minute, but we'll come back. I'll stop periodically and ask you if you do have any questions. We also, I should have mentioned, we will take a little bit of a break just so you can refresh your water and whatever. So we'll take a little break before 3. So what I want to talk about next, we could go to the next slide. And, actually we do have a question. I'll just so I've got a question here. What if parents are criminally dysfunctional or are sexually abusive? And which is a very good question. A lot of people in trainings want to know about if parents are drug abusing, if they're if they're actually harmful to the adolescent. And certainly, if there is any kind of abuse, we, of course, have this, we follow all the standard things that you would follow about reporting. We work with families around doing reporting if there's physical, sexual, any kind of abuse. Many, actually, of our parents over the years have their own history of crime and drug abuse, probably more often than not. So there's not really a short answer to that, but what we will, as we continue the webinar, you'll kind of hear how we work in the parenting domain. And a lot of work is done with parents directly. We'll talk about that after we go to our break, exactly our way of working. But essentially the shortest answer would be that we're going to work directly with parents around their own functioning, whether they need psychiatric help, whether they've been in and out of prison and need help and resources. And so a lot of the model is actually working one-on-one with parents around their own functioning and really getting them to the place where they're functioning the best that they possibly can for the teenager. In some cases, of course, and as the question is probably alluding to, with sexual abuse or any kind of abuse that's harmful to the adolescent, we would of course, not be trying to go against, anything that would be in the interest of the child. So certainly DCF our Department of Children and Families in Florida is called, and we work with them closely. And if parents are not able to have the child safely in their home, that's that's up to DCF. But we continue working if there's any possibility to keep parents and teenagers together, and more often than not there is, and of course we'll reach out to other family members. Sometimes you have to find an aunt or grandmother or somebody that can have the child in their home if there's really nobody else. But parent doesn't just mean a biological parent. It can mean anyone that is the guardian, anyone we can work with. So that's not sure. We'll come back to the parents functioning and how we work there. There's another question here about how long the model has been in existence, and I'm not sure, I might have just said that quickly. We've been working in our research studies, and Howard Little started to develop this model in 1985, and in San Francisco Bay Area, and we've done studies all over the country, and now implement in the United States and Canada and in Europe. So it's been over 26 years or something like that. Just got another question too. Do you work with foster care kids? And we have. The answer is that we have done work with foster care kids. What we've found works best is if we have a foster care parent who has been in the adolescent's life for some amount of time, that has some kind of connection or attachment to the teenager. It doesn't work well because so much of the model is based on the relationship between the parent and teenager, and really leveraging the love and the commitment between the parent and the teenager. So it has worked well when we have foster parents that have been in the child's life and have some kind of commitment to the teenager. And so we haven't done research with foster care kids, but we've certainly had teams implement the model in different places and have used it with foster care kids. So, okay, great questions. Thank you. Obviously, much more interesting to be able to respond to what you're interested in. So keep the questions coming. I'll move on to our next slide, but I'll right before we take a break, I'll come back to more questions. Okay, so sort of back to the slides here. We're looking at the slide. I hope all this is coming up okay for you guys. The slide is, we're going to move into the area of therapist behavior, so kind of what it takes to be an MDFT therapist. And lots of people have questions about this and email us, what does it take? And, my agency hears about MDFT and hears about other models and wonder what this is all about and kind of, what does it take to do this? And so the first thing that we talk about isn't even so much practical things, but really a therapist's mindset or therapist attitude. And we believe, and we found over the years, therapist behavior is really fundamental to success. That kind of is it's a really cornerstone of the model. And actually, I think a lot of our success is based on the emphasis that we put on therapist development and the therapist mindset, the therapist attitude. So MDFT therapists are believers in change, so optimistic, even in the face of great adversity and families that have lots of strikes against them and very few resources. The MDFT therapist believes in change, believes that even the kid it looks like is all strikes are against them. We look for every possibility, every strength, every possibility that the teenager can change, that the family can change. And this is not easy with some of our families that have so much that's piling up and so much adversity. But we're we're just optimistic about change, and in our supervision and in our training, we keep that at the forefront, that anything's possible, that kids' lives can change, that it's not too late, and we transmit that attitude to parents. So similarly, we're looking for strength. So you hear that a lot in trainings and things, that we have a strengths-based approach to that kind of thing. And but to really look for strengths, to really in every way of your work, looking for strengths, looking for how things that seem to be a setback might be an opportunity, where there might be a crisis, that's actually an opportunity for change. We really look to respect and admire the parents and the teen, even if we think they're not parenting the way we would, or even if we think the teenager's making really kind of crazy decisions and things we don't agree with. We're really looking to see the family and the teenager better than they see themselves. We want them, because when kids and families come into treatment, they're pretty beat up and they can be even pretty hurt by the systems that have been trying to help. And so we've all had that experience of families saying, we've been in many treatment programs and nothing's really helped, and parents sometimes feel blamed and criticized, and teenagers feel sometimes harassed, and especially our kids that have been through the juvenile justice system. So they come to treatment really pessimistic and a lot of the times really hopeless. So if we can look for ways to build them up in every little way. So we look for strengths. And MDFT therapists also are comfortable working in close proximity, emotionally and physically, actually. So our work is home-based. We're very much in the adolescents and the family's life with them. It's an intensive model which we'll talk about a little bit more in a bit, but the idea of working in close proximity, that we say to parents and teenagers, and we mean this, that for the time that we work with them, we really join their system. So we want the most effective way to help them is to really join that system for the time that we're with them. And so we really are part of that, part of the parenting team. We're trying to help in every way and really get into their world, so to speak. The number 4 talks about our attitude that therapists have of we will do whatever it takes in the time span that we have, and however much we can do. You can't do everything, and sometimes despite your best efforts, you're not going to change the world, but our attitude is that we express this to parents and teenagers, we're really driven to do whatever we can, whatever it takes to help, and we want parents and teenagers to feel that from us, and that, of course, that goes a long way to engagement and motivating them, because they're many times feeling very beaten up and hopeless. So, of course, the next one sounds really not really common sense, but sometimes it is hard when you have a kid and you're working like a dog and they're not doing the things that you really want them to be doing to make things better. It's so important, and we stress this in supervision and training, to maintain a non-punitive and non-judgmental attitude always, even when kids are really messing up. So this is a tough one. Nobody thinks that they're punitive and judgmental. Nobody wants to be, but the importance of the good supervision, close supervision, that we can catch when a therapist is feeling a little judgmental and coming down a little bit on the kid or the family. And the last one is that the therapist is always looking to improve their own skills. So we may come to do a training somewhere in an agency, and a therapist is very experienced, and they've done 20 years of work with these kids and families, and they've done family therapy before. And the person that's most likely to be an effective MDFT therapist is someone that says, I've worked in the field, but but I sense that I can do better. I sense that I have something to learn, someone that's looking to even do better, get better outcomes and improve their skills. And so those are the folks that do just really, really well with MDFT and do really well with the families. So that's the kind of the mindset or the attitude of MDFT therapists. And if you can switch the slide, you should see there's a little boy that's this is a Microsoft commercial from it was a few years ago, and this is a little boy who's kind of goofing around in class, and the other kids are distracted and goofing, giggling and goofing around. And we like to show this slide because this is an example of how therapists, MDFT therapists, see kids better than they see themselves. So this little kid's goofing around in class, and it sort of goes to the teacher, who's a little irritated and annoyed, and the teacher basically is frustrated, and she's got a kid in class who's basically making it distracting for the other kids, and so the teacher just sees kind of a knucklehead kid, right? So if you go to the next slide, and then you'll see this was the Microsoft commercial. So Microsoft does, and you probably remember these commercials. So Microsoft doesn't see a knucklehead kid goofing around. Microsoft and the MDFT therapist sees a budding astronaut. Microsoft and in MDFT, we see the potential. We see what can be. That's where we focus our lens or focus our attention on what this child can be. So we're not looking at the negatives. We're not even when parents are complaining, or even when the kid is very negative and very pessimistic. We're focusing on the potential, what this teenager can become in the world. So we like to show that. If you can move to the next slide. There's a little quote here from the Harvard Business Review, and this again goes to the mindset of becoming a great therapist or an MDFT therapist. And we like to talk about this with therapists in training, that experts are always made, not born. So this was a great article in the Harvard Business Review. It's really interesting, and it was a review of all disciplines, not just therapy, but artists and painters and sports athletes, and it reviewed basically how people became great at their discipline. And it says, one of the conclusions, the journey to truly superior performance is neither for the faint of heart nor for the impatient. The development of genuine expertise requires struggle, sacrifice, and honest, often painful self-assessment. There are no shortcuts. You will need to invest your time wisely by engaging in deliberate practice that focuses on tasks beyond your current level of competence and comfort. And so one of those areas that almost always we find when we go out and work with agencies and therapists, one of those things that's, even for people that have worked with a lot of families, one of those areas is working with parents and families, that to get families together in the room. Anything can happen. A lot can come up. There's, with our families, a lot of deep hurt, deep resentment, a lot of pain. And so therapists, this is usually an area that almost any therapist in our team, even our trainers, we can always get better at helping families and helping move families closer together, because it's such hard work and it's got such complexity to it. So we always stress this, that experts are always made and not born. And I'm from Chicago, so I'm a Bulls fan, and I always use the example of Michael Jordan, who some of you know him, and he may have known he didn't actually make his high school basketball team in his I think freshman year, and he didn't just give up. He didn't just get mad. He went out and he practiced and practiced and practiced the things he wasn't good at. So Michael Jordan or Tiger Woods or great artists, they practice the things they're not good at. And that's what distinguishes an expert from an average in any discipline. So we stress that, and again, the family work is usually the most challenging and the most frustrating it can be. Okay, so we'll go to the next slide here, and it talks about each MDFT session. Really, no matter what you're doing, if you've got an individual kid or parent or the whole family together, or a probation officer, every session that you do in MDFT has this inherent structure to it. And it has inherently in it has a lot of planning and reading feedback and adjusting. So the first thing we always start with in our therapy is a good plan for a session. So we want the therapist to be have already thought through their session with the goals, what they want to accomplish, and how they'll accomplish them. So our therapists, even advanced therapists, they write out and plan every session, even in a very shorthand way. But what do I want to accomplish today, and how will I help accomplish that? Then you're in the therapy session, and you'll implement your plan, of course, and lots of things come up, and you'll read feedback from the people in front of you, the kid and the family. How is it going? Do I need to make adjustments? Adjust your plan and your interventions. And then, of course, implement a new plan if you're reading the feedback that you need to make a new blueprint for your session. And then you continue. So then you continue to read the feedback and adjust. And so our therapists in training are taught to do this for every session. And it's one of the things that when we come away from trainings, when we certify folks, we work about 6 months with people to certify them. And this is probably one of the things that we hear most often is very, very, very helpful, is just this coming into a session with a really good plan and learning how to read feedback and make adjustments and change things up if needed. So that's kind of our way of helping therapists to implement things every session. So we'll move to the next slide, which is MDFT implementation issues. And again, this is just for folks that have some interest in finding out more exactly what the whole implementation system is and what it looks like in practice. I just put in a little bit here for those who are interested. So when someone says we really want to implement MDFT, we'll start with a conversation about a little bit about the model and kinds of things we're talking about here. And then we'll talk about, and we'll tell folks that to do MDFT, you need to have a team because it's such intense work, and it's a intensive model and takes a whole team really to implement it. So in training folks, we'll train folks as part of teams and agencies and in practice settings. So it'll have 2 to 3 full-time therapists. You can have a larger team, but usually folks start with a 2 to 3 full-time therapists, master's level. And we work in a team approach also with someone who would be called maybe a case manager. We call as a therapist assistant because we also, we of course think about case management, but we also think as that the case manager is really assisting the therapist to implement the therapeutic plan and the intervention. So the therapist assistant can be high school or bachelor's level, but we would look for someone who's very energetic, very good working with people, working in systems, not savvy, kind of street smart. So for 2 to 3 full-time therapists, we'd have 1 therapist assistant that would help with all kinds of extrafamilial needs. Some kind of, of course, on-site administrative supervision. And what we look for in MDFT, or if you're thinking about MDFT in your agency, we really look, and you'd be looking for therapists who have experience, of course, with substance-abusing teens and delinquent teens. Some experience with family therapy is really helpful, just because so much emphasis is on the family work and how to repair the family relationships and work on parenting practices. it's really helpful to have therapists who are comfortable and have done some home-based work. They're comfortable working in the community, not so much kind of sitting in the clinic and waiting for families to come in, but really out there, ready to, again, do whatever it takes and go out into the community, go to court, go to school. And as that last little point there says, interested in treatment innovation or interested in expanding their toolkit. They're interested in doing better work or doing more effective work. We'll move to the next slide, and this is about MDFT implementation, just a little bit about clinical case characteristics. So if you're thinking of MDFT and implementing and you wonder what kind of cases we would see, these are the kinds of cases that we've done research on. So we get lots of questions about, does MDFT work with, bipolar kids, or so we stick with really what we've studied, and so we would want therapists not to be overloaded because the cases are intense and we do so much work with them each week. So our caseload is low. It's 5, 6, 7, 8. We would go a little bit higher if there were prevention cases, but not much more than that. Maybe 10 at the most if they're prevention or early intervention. So one therapist would be at any one time just seeing 5 to 8 cases. And we do look for cases that are primary substance abuse and or delinquency. Almost every kid, of course, you know from your work that kids in substance abuse and delinquency have many other problems, and which we have in our studies as well. So it's not that we don't have kids with comorbid problems. We actually, most of our kids do, but the primary problem is generally the substance abuse and delinquency. And then they may have a depression or anxiety that is with that. But if it's a primary bipolar disorder, we haven't researched MDFT for primary bipolar disorder. So we wouldn't be comfortable saying that, yes, that would be a good treatment for it. Our treatment cases stay about 4 to 6 months, depending on the severity. And actually, if they are prevention, which we've done a lot of prevention, the cases really can be more like 3 months. And again, pretty intensive, average of 2 to 3 sessions per week with the TA work, which is the case management, the extra familial work. And then phone contacts throughout the week. We're in touch with we're in touch with the families throughout the week to find out how things are going. Is there anything that any new things that have come up or any barriers that they're experiencing? So we're on the phone throughout the week with kids and parents and throughout the weekend, sometimes if there's a crisis. So that's a very brief discussion of the kind of practical implementation issues before we talk about the model itself. And I'm thinking we're on schedule here to take a little bit of a break, but before we break, I'll go to some of the questions, and let's see here. Okay, so I got a question. So MDFT sounds a little like a strength-based approach. Is MDFT a sister or brother similar to solution-focused? And I mentioned probably really quickly that Dr. Little, who developed the model, was mentored by Jay Haley, and so very much influenced by problem-solving therapy, very much, as we discussed, very much focused on looking for strengths, not looking for what's wrong, but looking for strengths, looking for what can be developed, what can be built upon. So certainly influenced by problem-solving therapy, for sure. Another question is about how important is it for parents who are not living in the home but relied on for support by the child with MDFT? And that's a great question. We do lots and lots of work with parents and other family members who aren't in the home but are very, very important to the teenager. And that just depends on the case. You can have a parent who's out of the home, like a divorced family where a father isn't very much involved in even the parenting, but is still very close to the teenager. So we still might do a lot of work on the teenager and the parent relationship, and we'll look always to help parents come together. We'll talk about this a lot in the next 2 webinars, that we're always, even if parents are divorced or separated, we're always trying to help them work together as a team, because the reality is they are the parents. And it's very challenging work sometimes, but we work, that's a lot of the parent domain work, is to help parents work together as a team. So good question. It's very important when we can. Sometimes parents just aren't available. Parents don't at all want to work together. Sometimes there's restraining orders, as the previous question about abuse and neglect. And so, of course, sometimes you can't do it, but whenever possible, we really do look to other parents, grandparents, aunts and uncles, anyone that can be a support to the teenager. There's a question, is MDFT the same as multisystemic therapy, Scott Hengler? Did one come before the other? MDFT is different than MST. These are separate models, and really they were developed completely separately. So Scott Hengler, you probably know, is in South Carolina, worked, his model came from really a family preservation model, and as I very quickly described, MDFT is developed really from adolescent development, parenting, risk and protective factors, and family therapy. So the distinguishing feature there would be that Dr. Little, in developing MDFT, has been is a family therapist, so very much developing the model based on family therapy principles and attachment and adolescent development relationships. And let's see. There's a question, I assume our number 4, which I'm not sure, is still within a motivational interviewing approach. Least we work to get kids to do what we think they should do. I'll hold off talking about motivation till our next seminar, our next webinar next week. Motivational interviewing, of course, is a wonderful approach and has you'll hear many of the same threads throughout. We don't do MI within MDFT. We have some similar things that both models just use basic good interventions to motivate kids and families. So we'll talk within our next webinar about, most of our webinar next week will be motivating and engaging kids and parents. So I'll hold off on that question because I want to definitely give you guys a break. A couple more questions here. Are the adolescents in substance abuse treatment at a different agency in conjunction with family therapy? I ask this question because historically, substance abuse treatment agencies are punishment-based. This is changing, but slowly. I'm not sure how substance abuse treatment and non-judgmental family therapy would work effectively together. So this is a great question, and it's a very good question. So one of the things that we think about and we talk with agencies about when we do implement MDFT is the substance abuse treatment. So it's not that kids go to a substance abuse treatment and have MDFT on the side. We're actually looking for agencies to change exactly what's said here. We want agencies themselves to really take on a less punitive and less judgmental approach. And this actually even extends to probation officers, school personnel. So as an MDFT therapy or an MDFT program, we're looking for the whole agency to transform. And we've been able to do this. We've actually got studies on transforming a whole program that was very, very kind of punishment-based and very behaviorally structured, and we were able to transform the whole program. But no, MDFT is not a separate thing. It's implemented within a substance abuse agency that is actually willing to change in those ways. So, yeah, it's a great question. And one more question before we take a little bit of a break. Does the therapist always meet with the family as a unit, or does the therapist meet with individual members or different groups of family members? And great question. That's actually what we'll spend the rest of our session today talking about, the different the different subsystems that we work. And so the short answer is no, we work individually with kids, individually with parents. We meet with families together. We meet with other people in other systems. So we'll talk in much more detail about that. And we'll also show a little clip of just an edited clip of a family that did MDFT with us, and it'll be at the very end of our webinar today. So let's take, let's say, just a really quick break, maybe come back at 5 or so, and we'll be continuing on with our intervention targets and how we work all these different things together. So take a little bit of a break now, and come back if you can at 3, maybe at 3:05. All right, great. I've just been emailed to continue. I thought I was supposed to give folks a break, but I guess not. So I'm going to actually go, just because I've told people to take a break, I'm going to go to another question that I got that someone was asking, and it's a great question. I'll just continue with that, and folks come back as they come back. There's a question about, again, MST, multisystemic therapy, versus MDFT. And someone is asking, if I were trying to decide to implement one or the other of the models, what are the primary differing features? The models look very similar. Sorry to ask this question in a different way, which no problem at all to ask. It's a common question. So yes, there are several. Actually, other than MST, there's also functional family therapy and brief strategic family therapy. And the thing that really defines all those models is that there's a primary theory that it's not enough just to intervene with a teenager, so that the family is a critical context to intervene in and primary context of development. But all of these models have a different way to change families, and they actually have different ideas about what needs to change. MDFT, as we'll talk about, is looking to change the many different things beyond even changing the family, but to change an adolescent's view of him or herself, to change how the adolescent is making decisions, thinking about who he wants to be, how he wants to be in the world. And the family work in MDFT is very much about changing relationships. That our fundamental tenet is that we need to have a relationship foundation, or a certain level of healing in relationships, a certain level of attachment, to actually have change in a family's ability to problem solve, or for parents to change their parenting practices. So our work goes very deeply into family relationships, things that are unhealed, things that need to be resolved at an emotional level, before we even ask parents or kids to actually change their behaviors with each other. So this all, of course, comes from family therapy models. And someone who's just been asking about the differing features of MST and MDFT, both are very much interested in altering the family as well as extra familial systems, so the ecosystem. So those are sort of hallmarks of both models. In MST, there isn't any work one-on-one with teenagers. They don't feel that that's essential work to do. So that's a very different approach. And most of their focus in MST is to empower parents, so to make parents stronger in their parenting, and stronger in how they negotiate with other systems. So that's kind of their primary focus, is to make parents really strong. And so I don't know if that answers your question, but both models are intensive. They work with other systems and home-based, and have really good outcomes. So it's just a matter of how an agency or a therapist resonates with. So anyway, you'll hear a lot more about what we do in MDFT, and we'll go sort of go ahead here, because I was prompted not to stop. So anyway, we have, let's see, we're going to go ahead, I guess, then to the next slide, and this is going to be a response also to one of those questions right before we took a little break. There are 4 intervention targets in MDFT, and these are the 4 corners of our work, the 4 different things that we do throughout all stages of treatment. So we're going to do work with the adolescent alone. We're going to work on the adolescent's ideas and sense of self, and who he or she wants to be, who he or she thinks they are and wants to be. The adolescent as a son or daughter, as a peer, as a student. So that first corner is the adolescent's world. The second corner is the parent's functioning, and so we're intervening one-on-one with parents, parents as team, as couples and teams, but also one-on-one. We'll be looking to I explore their sense of self and their own functioning, as well as how they're functioning as parents. So we really believe parents aren't going to be able to make changes in their parenting if they're not functioning at the best possible level. So in our webinar next week, we'll talk about how we address the parents one-on-one and their individual functioning, how they're taking care of themselves. Do they have all the support that they can possibly get, and are they functioning as well as they can, so that they're in the best shape to parent more effectively. So we'll do a lot of work with just parents. Then the third is our family interaction and family relationship corner, and that would be the more, as you would think of, as sort of traditional family therapy. And what we'll be targeting there are changes in interactions, changes in transactional patterns. So we're looking, of course, how families interact with each other, and how how they interact tells us about their personal functioning, right? And we're going to want to find out about relationship history and things that have been difficult, things that are still standing in the way of doing really good problem solving day to day, and how they're functioning together, basically. So that third dimension in our model is family therapy, family relationship change. The fourth corner is extrafamilial work, and so that's the multisystemic work, or people call case management. And so our interventions there are helping teenagers and parents to be more effective in how they're dealing with other systems and getting their needs met. So they may be helped in many, many, many ways with finances, housing, healthcare, mental health services, psychiatrists, school, court. So our extrafamilial focus is aimed at eliminating barriers to treatment and to help sharpen their skills in negotiating with other systems. So those are the 4 intervention targets. And if we, let's see, if you can move to the next slide, there's a graphic of basically how this goes. So if you can sort of push the first little button there. So we know that problems are multidimensional. There's a little graphic there of that upper left-hand corner. So problems are multidimensional. And if you click again, we have a little box in the right-hand corner there. Multidimensional problems require multidimensional conceptualization. So that's just what we said a little bit earlier, that if you know that adolescent drug abuse and delinquency have lots of risk factors and protective factors that operate together, then of course that lends itself to thinking in a more complex way about adolescent drug abuse. If you think that way, you're not just going to think a kid has a disease or the kid's actually just acting out. So thinking in a complex way is going to, if you click again, it's going to yield a multi-systemic way of thinking about intervening. And so the last little, if you click again, there's a last box there. MDFT assesses and intervenes into the multiple systems of development and influence. And so it's just kind of a graphic of exactly what we have just been talking about, the logic of the MDFT approach. So sort of to say it in one more way. So if we know that adolescent drug abuse is multiply determined, that there's many factors that go into it, that lends itself to a complex way of thinking about adolescent problems. And then if we're thinking that way, we think, well, gosh, we've got to have an intervention that covers all these different factors, that it's going to intervene in all these corners. And so MDFT does that. It assesses and intervenes into these different systems of influence. So if you click the next slide, we're going to get into pieces of MDFT, the pieces of the MDFT approach. And what we'll do the rest of this afternoon is just in a very global way, in a kind of a thumbnail sketch way, we'll talk very generally about about basically what we're trying to do in each domain. In the next two webinars, we will be going into much more detail. So do go ahead and send questions, and if we have time, we'll get to all of them. But I want to just give you really an overview of the approach today, and then in the next webinar, we'll do much more detail about the different interventions. So in this slide, the pieces of MDFT, it's just a graphic illustration that this slide here shows the therapist working with the adolescent. And so we will spend, throughout the therapy, a good amount of time one-on-one with teenagers. So even though Dr. Little, the developer of MDFT, was trained as a therapist, family therapist, he, in working with kids and in working with these kinds of cases, he really always felt that that one-on-one work with the teenager was essential. That really, you sort of put yourself at a disadvantage if you're going in to try to do family therapy without a sense of who this teenager is and who this teenager wants to be, their perspective on things. It's hard to engage kids or get them motivated and excited if they don't feel you're on their side, if they feel that you as a therapist are really just there for the parents. So always, as part of MDFT, there's been a big focus, a huge focus on the adolescent's world and the adolescent's sense of himself or herself. So in across the therapy, there's always one-on-one sessions, and the basic idea there is to facilitate with the teenager their own self-examination, to facilitate in a way that's just very that's hopefully stimulating to the teenager, that engages the teenager in looking at themselves, in thinking about where their life has gotten off track, to kind of enter into this puzzle or mystery. And that's kind of how we'll present it. Like, things have gotten off track for you, and, you know, all these sort of forces are trying to get things under control for you, but how do you see it? What do you see as the problems in your life? And a lot of times kids will say there is no problem. Like, if everybody would get off my back, there would be no problem. So we just start with wherever the kid is, and usually what we'll find early on is kids can always complain. That there's rarely a teenager that has no complaints about their parents or school or even friends. So we're really looking to let them just give their perspective, give their view on their life. And we really instill for teenagers that they of course are the expert on their life, and it's a different thing for them to hear. It's very powerful for a kid to hear, I listen and understand your complaints, and I think it's really valid. I think you have valid things you're worried about, and that you present to the teenager that you are there to help deal with these concerns. Even things like, you know, your parents could do better for you. it sounds like you're just really right on about that, and it's very powerful for kids to hear. Our kids that have been just kind of beaten up in the systems and feel hopeless and feel no agency to change. So, so this individual work with the teenager, very important. It'll continue throughout therapy, and you're always trying to get the adolescent to sort of think about themselves and bring that voice into family therapy, into how they deal with people at school, and you're helping them, but you're really empowering them to do the work that's needed. So that's the adolescent in a very brief nutshell. We'll get into a lot more detail about that, but we'll go to the next slide in the pieces of the MDFT approach that it'll show a red little circle there. The therapist works extensively with the parents. And again, this doesn't have to be a biological parent. It can be, a lot of times, we're working with divorced, separated. We're sometimes working with two sets of parents because parents have remarried. So, a lot of times we're working with grandparents, and that they're still, the parent is still involved, and the grandparents do a lot of the parenting. So this is complex and difficult and very important. So we do a lot of one-on-one work with the parents. And there's two main areas here. There's the self of the parents, the kind of individual functioning, how they're handling stress, and really resonating with their concerns, really validating the work that they've done on themselves and how hard their journey may have been, and the efforts that they've made to improve themselves. And so we're really working, as I was just saying, we want to help them get to the best level of functioning that they can be, so that they'll be able to be better parents and be more available, more effective. And in doing this work, we'll identify things that can be helped by case management. So we may identify a parent has some depression, or just heavily burdened by a housing foreclosure that's imminent, or things like that. So we identify things that we can help in different ways. So that's one major area of the parenting work. But the second, of course, is the parenting work. So as we've gotten them to a good place, they're at least taking reasonable care of themselves and addressing basic needs, then we're going to help them look at their parenting and how they'll show their love and commitment. That's where we start always with parents, is demonstrating their love and commitment, demonstrating that to the teenager that they love and care for their child, and that they are willing to hang in there even if they don't feel like they are willing to do that. We'll talk next week in more detail about how we do that. But and then we'll spend a lot of the therapy, a lot of the kind of heart of the therapy is helping them with their parenting practices. So helping them do better monitoring, more effective limit setting, and setting structure, and follow through, and being involved with school things that are happening, all the different kinds of things that we know goes into good parenting. So that's the parenting domain in a really brief nutshell, and we'll go to more detail in the next couple weeks. And then if you go to the next slide, there's the next slide of pieces of the MDFT approach, and the green circle there shows the family therapy corner. And the family therapy corner would be as I said, the more traditional family therapy sessions where we bring everyone together. And when we start, we're going to try and start with all the key members of the family that are involved in the adolescent's life. You can't always start with everybody, but try to make a good start. And we really just try to get everyone's perspective on the table. So the family therapy sessions are, in the early stages, they're going to be a lot about where the members of the family feel things have gotten off track, what they're upset about, what things are most important to change. And generally, even if you have families in lots of conflict, generally you can find when you're looking for some point of agreement, and generally people can agree at least that it's very tense at home or that they wish things could be better. Many times you can at least get parents and teenagers to agree that they sort of don't even know each other anymore. That teenagers will say, my parents don't understand me, and parents will say, I don't understand this kid. So that's a lot of times you can at least get that kind of an agreement that things aren't good. Things just aren't the way we want them day to day. It's no good for anybody. So in our early family therapy sessions, we'll really look to bring out onto the table what each family member wants to change. And even if it seems like it's all over the map or that there's just so much conflict and disagreement, usually there are some points of agreement, and that's what you'll look to highlight, that they love each other, that if they've even just the fact of them being willing to come to the therapy means that they care for each other deeply, and that they're and that we're very optimistic about families being able to change. That we'll convey that in lots of different ways. That families, when they come together, can do the impossible. That anything really, teenagers can change their whole lives, and when parents and teenagers come together, there's nothing that can't change. So we'll really look to highlight things like that, like just families committed to each other, loving each other, wanting things to be better. And then as the family therapy goes along, we're looking to be we're always looking for that, for the healing relationships and the connection, and highlighting how the connections and the relationships are powerful, and anywhere that we need to continue to go deep into those things. But as the therapy goes on, a lot of the work is also just day-to-day problem solving. So the day-to-day things that come up, the curfew, the family rules, the things that the parents are trying to change, bringing those things into the family therapy sessions. And same as our work with teenagers. So teenagers may talk about things in their individual sessions that we say, I think this is so great that you're talking about this, and we need to bring this to your parents. Your parents have to hear this. I think you're absolutely right that they need to change, that this is a really important thing for you. And so you're going to bring, from your individual work with teenagers and parents, you're going to bring those things into family sessions. And then so that work is just kind of ongoing, day to day, week by week. It gets deeper. It goes to core things that they're ready to deal with, and it goes to just the daily problem solving and chores and rules and things that are going wrong in the house, and of course it goes to the drug use. So in the family work, we're bringing in results of urine screens that we do with the kids regularly, and we're bringing those into family sessions for the family to deal with and talk about together. So the drug use is always brought out into the table for the family to talk through and deal with. So let's go to the next slide, the last piece of the MDFT approach, the fourth corner, so to speak. And this is the maroon circle there, the extrafamilial. And this is what people call case management. Sometimes we call this the extrafamilial or the therapist assistant tasks. Not just that the therapist assistant does, but the therapist and the family and therapist assistant together. And these are all the other systems that are influential. So we know that if we don't deal with things that are unraveling at school, we can make lots of progress in family therapy and talking with kids, but things unraveling at school, that's no good. Or things happening in the juvenile justice system, if we're not on top of them, a kid can get sent away, or a kid can be sent to a program. Or we want to be on top of all the different things that are happening in the other systems, and of course getting families' needs met through social services and medical care and things like that. So this is the area that's very big and a lot of work, but it's really critical because we've just found over the years, we've actually probably done more of this in our different sites, that we've found you can do good work in changing family patterns, but if you aren't addressing the other risk factors and the issues in school, we're not helping the kids in the maximum way that we can. So we'll talk more in the next sessions too about the extra-familial work, exactly how we coordinate all this. Okay, if we can go to the next slide, there are across these four corners and across the stages of treatment, there are key interventions that we do really kind of no matter what, and no matter who we're working with or what stage of treatment or really what kind of case. So let's talk about this briefly, and then we're going to show a little video, a little edited example of MDFT. So key intervention actions in MDFT, and again, these are across the domains and stages. So the first is to develop and maintain multiple therapeutic alliances with the teenager, parent, and people in extrafamilial systems. So we're going to talk in detail about this next week, about how we develop these alliances. Actually, we'll talk about the first two, the engagement and motivation to change. But just to make some brief points here today, if you don't have engagement, of course, you have nothing. So we're very, very preoccupied with about developing and maintaining multiple alliances, because you're dealing with lots of people, and you'll have to negotiate. It's of course tricky because you've got you never want to have the teenager feel alienated, but sometimes you really do stand with the parents on a certain issue, or sort of like really empower them, and you're always kind of negotiating and working back and forth with. You're really on everyone's side, because your ultimate goal is to make things better in this family, make things better for this kid. So you're sort of on everybody's side, but it can be a tricky business. So this is one of the things across therapy. It's not just something you do the first few weeks of therapy and then you stop. So this is key. This is something we're always thinking about. Enhancing motivation to change. So similarly, it's not just something you do for 2 sessions and then people are motivated. We'll be talking about this a lot next week, but the main idea here is that people are motivated to change when they feel that things are urgent. So in your own life, you think about when you've changed something in your life, it's usually not because everything's going great. It's usually when you have a sense of things aren't going so great, and that there's potential for great loss or great risk if you don't take action. So enhancing motivation to change is not just something you do once and then you're done. It's constant throughout therapy. Sometimes you'll have an adolescent who comes into therapy sort of motivated and stops using and does reasonably well in their work with their family and doing better at home. But when kids start to do well, sometimes parents actually lose motivation and they've got busy lives, right? So throughout therapy, we want to really bring parents back and teenagers back to the urgency about doing the hard work, doing kind of what it takes. And so we're thinking about motivation to change throughout the therapy, and use crises to your advantage. There's lots of ups and downs, of course, with kids in therapy and parents, and so you use the crises as motivators. You use the crises as opportunities, and to create focus and urgency and intensity. So the third bullet there is, of course, that you develop collaborative, respectful relationships with teenagers and their parents. That's seems common sense, but as somebody did ask in their questions, that in substance abuse treatment, there's just kind of a long tradition of being a little punitive or being a little even a confrontational approach, like thinking that that's helpful. And we generally find that that's not helpful with our teenagers. That of course sometimes you're gonna feel that things are very, very urgent, that things aren't going so well, and so you're going to convey your urgency or your concern, but always in a collaborative way. So we want to present to parents and kids that we're not the expert on that, on their family. We know a lot about teenagers and drugs and court and families, but we're not the expert on their lives. So we're coming in really to be a collaborator, to join with them in changing a teenager's life. So we'll move to the next slide here. This continues the key intervention actions across domains and stages. So another major thing that we're always preoccupied about is, are we thinking about all the different possibilities for change? Are we sufficiently oriented to how things need to change and how we can leverage different systems of influence to create change? So this whole idea of multiple change targets, and that's the advantage of having a multidimensional model or a multisystemic model, is you can start things with a therapy case, and you actually may not get a kid who's super motivated or even very engaged, but you just start your therapy, right? And so there's multiple change targets. You can start. You do all the work you have in your model to do, but even if you're not making great progress in the one-on-one work with the teenager, you may have someone in the parenting system who is very motivated and who's actually very just really enthusiastic and willing to start right away to make changes. And that can influence a teenager who feels pessimistic and hopeless. So seeing some changes in the parent can actually motivate a kid. Or if you make something happen in school, or you make something happen with the probation, these can be huge sources of influence in your therapy. So these are the ways we're always thinking that am I covering all my bases, and have I leveraged everything I can possibly leverage this day or this week to make change, to create change. We've mentioned this before, the second bullet, identify and enlarge upon strengths and competencies. And this is a J. Haley term. We're not psychopathological sleuths. We're not looking for all the things that are bad or wrong. And even though no one would say, yeah, I'm always looking for what's wrong, it's a very common thing to slip into, even with advanced therapists, that you have hard cases, you're tired, you're working really hard, and it's easy to get into the things that are wrong with kids and families, and we always want to watch that. So we're always looking for, even in adverse circumstances, what can we build on? What can we make bigger and build upon? What can we make, how can we enlarge upon strengths? And relatedly, with the family, the third bullet, we're always going to celebrate small successes. We're always looking for how even little tiny things that don't seem huge, we're going to make those really big and highlight them, amplify them, have parents and kids talk about them. You'll actually see that in this little segment that we're going to show in a minute. It's maybe 2 months into the therapy with this case, and the therapist has the family, the boy and mother, just stop and tell each other all the different ways that they see changes. And this is only 2 months into therapy, so a lot has already changed. But if parents and kids don't take the time to look at those changes, they can go unnoticed. And so we want to spend a lot of time to celebrate small success. I like to use the example of an adolescent who, maybe an adolescent hasn't been in school for a month or a couple of months, maybe had a expulsion or something, and then has gotten back into school, but really doesn't, really not excited about the new school. And so in their first week back, they go on 3 days, but they don't go twice. They go only 3 days of the 5 days. And so rather than focus on the 2 days that they didn't go. We're going to focus on the 3 days that they did go and make that really big. And like, so how did you do that? That's huge. You haven't been in school for 2 months. So how did you do it? How, have the parent and kid talk about that was a huge success so we don't want to focus on the 2 days where they didn't go, but we'll make it really big that they did go and look for clues as to how that happened, what went into the success of that. Okay, so if we can go to the next slide, this is just the final slide about key intervention actions. And again, these are things we're doing throughout the therapy with everyone, no matter who's in front of us, no matter what stage of treatment. The bullet here is referring to facilitating meaningful discussions between kids and parents. So really getting to the heart of the matter, getting to what's upsetting kids and parents, what's real for them, and enhancing mutual understanding, helping them resolve conflicts. Again, so if you wanted to know how MDFT stands out in the different family therapy models, this would be something people would say regularly, that as therapists, even though it's challenging work, it's something that therapists love to do because they know they're getting to the heart of the matter. They know that what they're getting to is they're breaking down barriers that are keeping families from day-to-day good problem solving or even talking to each other, right? So we all know from our own experience that deep emotional hurts and resentments can keep kids and parents from doing anything together, any kind of good interaction, and for years and years. And so we want to deal with these things, get them out on the table, and help parents and kids talk about them, deal with them, resolve the hurt and disappointment, maybe come to forgiveness, but if nothing else, come to a place where they can at least even agree to disagree, but to at least get to where they're able to discuss and talk about. The next bullet, find workable answers to current problems. So even though we do a lot of this emotional work and resolution of hurts and disappointments, there's also a lot of just practical, what's happening day to day, how are you dealing with it, problem solving. So this will be more like the middle stage of therapy, the day in and day out, what kinds of things are coming up around. A lot of stuff comes up, school stuff, curfew, the drug use, how are the parents dealing with the kid being out, coming home high, or getting caught at school with whatever it is, or even just chores and things like that, homework and stuff. But workable answers to the current problems and helping them do the work together. And in a second, when we show this little video, you'll hear the therapist, Elda, you'll hear her say, today I want the two of you I don't need to really even do much. That the two of you just really talk together. And that's the heart of MDFT family therapy work, is the technique of enactment, that the parents and kids together do the work, and that the therapist is really just a facilitator, coaching, shaping. So, and then this last little bullet here, failure and crisis are opportunities. So even when things feel very sometimes scary, here in Miami we've had, I've supervised cases here, and we've had just really scary stuff with kids, gang-related stuff. One of our kids stabbed and very close to death, and so things can look very, very scary. But we always want to look for the opportunity in a crisis, and it always is an opportunity, because when kids are in grave danger or when families are in crisis, people are more motivated, and it's easier to focus and motivate people when they're upset. And when things are going well, it's not so easy to get people coming for help and coming for doing all this hard work. So even when things seem like it's all is lost, or this kid's going to get sent away, we never stop. We even if a kid is being sent away, we're going to try to do everything we can to help that family and even plant seeds for when the kid comes home. So, okay. So the next slide, there's just one more slide before we go to our video, and this is just in a very quick way talking about the 3 stages of treatment. So we have 3 stages. Stage 1 is to build the foundation, and this is developing alliance and motivation. And we'll talk next week, next Wednesday. We're going to focus totally on stage 1 because it's a good foundation is, of course, very, very critical. So stage 1, and that can be a couple weeks, and whatever it is, a week, or it depends on the motivation and alliance that you're able to develop, but generally a couple weeks or a few weeks. And then stage 2 is working the themes that you've been identifying are critical and helping and requesting and helping kids and parents change. So that's like that's the heart of the therapy. That's several months of work, very very intensive, and working all your different corners. And then in stage 3, again, it's maybe a few weeks at the end of therapy, seal the changes and exit. And so in stage 3, we'll talk about stage 2 and stage 3 on November 10th. In stage 3, you're basically going to really highlight the changes that they've made, and you're going to launch them into whatever's next for them. So MDFT, we really make a big deal about time, that we want to keep people focused on. We don't go on for years and years because we want to work in a very focused way, in an intense way, for 4 months or 5 months, whatever the family needs. But we don't drag things on because we really want to help people stay very focused and achieve. We want them to feel like at the end of this program that they've really achieved something, and they usually can come away feeling like, even if things aren't perfect, that they've really come together and really accomplished things. So those are the 3 stages, and as I said, stage 1 will go into in depth next week, and then stage 2 and 3 we'll talk on November 10th. So whatever a case, and I'll actually respond to one question that I got, which was in family or systems, family therapy, that there's a systems way of thinking where you try to maintain empathy with everyone, and how do you do that if you meet alone with the teenager? And just to emphasize again, MDFT goes beyond traditional family therapy. So that's exactly right that the person had said. Often there are theories that say you really just want to meet with the family, so you don't have sort of different work happening and different levels of engagement. But in MDFT, we found that actually it doesn't hurt at all the work that you do one-on-one, as you see in this case. You actually see that the one-on-one work with the parent and the one-on-one work with the teenager actually has a beneficial effect on the work that can be done in the family session. So without that work with one-on-one work with the teenager, you wouldn't have a perspective from the teenager that says, here's what I'm concerned about, and that then being able to bring that in. But the question's very good, is how do you negotiate those multiple alliances, and particularly if you have a teenager that's not so forthcoming. And so we're going to talk a lot about that next week, how to keep these alliances moving, and how to negotiate and keep from getting into trouble. but it can be done, and we're essentially just doing the best we can with all that, and being very honest that it sometimes feels like we're playing both sides, and we are, because we're really trying to do the best we can do for everyone in the family. And so you saw that here, that there wasn't just a focus on how the teenager was going to change. There was also a focus on how mom had made incredible changes, really, really good stuff, had been not drinking for 2 months, which was a very important thing for the teenager. And so it was addressing not just the teenager's concerns, but and not just the parents' concerns, but really how they work as a unit, how they come together. And so you saw them talk about the progress they've made and their real good problem solving at the end with the little contract, and just a great progress and great case. So I would just like to show that and give you a little view of it. Of course, it's not everything that happened in that case. There are a lot of ups and downs and crisis and that, but anyway, that's meant to give you just an overview, and I'm so appreciative of all the great questions, and I hope you think about more that you can even bring to our next session, and we'll be talking again next Wednesday at 2 o'clock Eastern time, and that'll be, again, focused on stage 1, alliance, engagement, and motivation. So thank you so much, and we'll continue on from here. Take care. Have a good week.